Good afternoon, the world. My name is Dr. Victor Tsang, and I am the Director of the Digital Dental Surgery Sydney. And I also have a small surgery in Gosford, and we focus our treatment on the implants. And we also have this training center to help to train dentists about the DIOnavi system. I'm very grateful that I have this chance to speak to all of you. And I understand that this webinar is on the topics of the full arch lecture. And I have been looking and learning a lot from my previous professor and doctor, like Professor Meredith have been showing everyone the surgical steps of how to do and perform this full arch case. And also Professor Choi before us has been explaining the concept and how he developed these step-by-step good methods of full arch. So I'm kind of a little bit shy to show my full arch case before this great man. And I sort of got requests to talk about a little different topics, and it is on the 10 things that we should never do when we're using DIOnavi system and what to do instead. The DIO company has been developing these methods and to try to help all the good doctor, all the good surgeons to perform implant surgery in order to avoid problems and avoid mistakes. And we are human, and fortunately we have the technology to help us so that we can avoid problems. A great man, Arthur Clarke, have once said, sufficiently advanced technology is indistinguishable from magic, which I agree fully. So technology that is available nowadays, it's quite amazing. Like I still can remember 10 years ago when Apple launched the iPhone, and they say, we are going to change the world. I didn't believe it then, but look at it now. See, the technology, it's so advanced. Everyone can use the web to search for things and to look for answer. And we have electric car that can be self-driven and things like that. So why not having the technology helping us to do implant surgery? And the DIOnavi system works like magic to me. So what DIOnavi system can provide with us is that with the treatment design and treatment planning and all that provide to us, it is a very good dental records for us to keep. And then it is also planned for us to use when we try to do the patient consent, because it's all there on the paper showing us how many implants we're doing, how the size of the implants. Is very good for us to do the consent. And all the design of these crowns and implant position is all prosthetic driven. And it allows us to place our implants perfectly and precisely. And this procedure is atraumatic, and it's allowed us to have the immediate temporalization to give us a predictable result every time. If we can do that, then we're having happy patients, happy doctors, and all our staff are also happy, because it just makes this surgery so straightforward and simple and easy to manage. So the full arch products and component that the DIO company can provide, it's great. So, but the thing is, say for example, these full arch products needs to place 4 implants or 6 implants or 8 implants to support our component. Every implant, we have to place it in the right position with the good torque, with the good stability. before we can issue our temporary bridge, isn't it? So I want to make this simpler, is that we also doing a live surgery later on after this lecture, and I'd like you all to observe. We're only showing you how to place 2 implants, but it's the same. If you can place 2 implants the right position, and you can place 4 implants or 6 implants, they're all the same. And then they help you to place the full arch correctly and directly. Then we can make our dental practice a smarter one with this personalized procedure that DIO can help us. But our topics today is about 10 things that we should never do when we're using the DIOnavi system, and what to do instead. If all those things that we do or we don't do can help us to improve the odds of success. So maybe you think this topic is boring, but if you stay with me until the end of this lecture, I think you're going to thank me for it, because that we have been using the DIO system for many, many years. And I tell you, I have made mistakes. And this lecture is to share with you my mistakes so that you can learn. First things that you need to do is the patient's expectation. Never do DIOnavi system without talking to your patient and listen to them, and never assume that you know them. Just spend your time to listen to your patient. Patient expectation could be very, very different from what you think. Say, for example, if I ask my wife, what do you think that she expects to be a good husband? Then she would say, all right, my good husband should hug me every day and take me to walk the beach, and then take me to do shopping, and then hug me more, and then take me to good dinner. Afterwards, do more good shopping. Well, that's maybe her expectation. But when she asks me, what do you think is a good husband or a good wife? If she asks me, I say, bring my dinner. That's all. So it could be totally different from what people think the expectation. So this is very important to ask your patients about their expectation, that you can get a lot of information that you don't know, because sometimes patient might expect that the treatment can be finished earlier, or maybe they might get surprised about the cost of the treatment and things like that. You need to listen to the patient's expectation, and if you can exceed their expectation, then you're winning. The second thing is that you never do your treatment without the consent and inform. This consent and inform should include what kinds of procedure you are doing, how many implants, the cost of the treatment, how long would it take, and if there's any other alternative treatment, and how many appointments that might take, and also the last is the possible complication. So there's no surprise to the patient. It is very important that you need to have a good consent and inform before you do the procedure. Thirdly is you never do the DIOnavi system without a good record, and that records including your periodontal charting, your condition of the TMJ, and then also the infectious control protocol that you're going to use for your surgery. To stick this, your surgical pack, the sticker, keep them. Periodontal charting is very important. I hope that all of you may be aware that there is new periodontal classification. And this new periodontal classification. I'm not going to spend time to talk about it, but please look for it. It is changed the concept of how we look at periodontal problems. It is looking at the periodontal problems like if it is like a cancer disease that describe the stages of the disease development, and it looking at the age of the patient and consider a lot of other things as well. If we have any problems with our implants treatment, say for example, the dental council might ask you something. One of the most common question that they ask you is that, is the patient better off or worse off? This is one of the most asked questions. Can you provide any evidence that the patient is better off or worse off? If you don't have their records of their periodontal things, you can't compare. You say, oh, no. Patients now have periodontal disease that they have that problems before already. I have this charting. But if you don't have the records, you can't prove. So this is a dilemma. If the patients have periodontal problems, why you start the implants treatment? So you have to treat that first. And TMJ is also very important records that you need to keep. What happens if the patient have your full arch treatment and then develop TMJ pain? Can you provide any evidence that the condition of the TMJ has already been assessed? And then is that because of your superstructure that's causing the TMJ? You have no records. Oh, you are already guilty. If you have the records, then we can talk about things. But if you don't have the records, you are already guilty for what you have done. So that's very important in these patients' records that you have to include the periodontal charting, even minimum periodontal charting, like whether there's any bleeding index. At least you have to mark it down, which quadrant, the bleeding index, and then the TMJ condition. Are there any clickings or any problems of difficulties opening the mouth or things like that? Or have patients been complaining if there's any pain or things before the treatment? It's all very important. So the second things that the dental council might ask you to provide is that, do you have any evidence of the infectious control protocol? That is also very, very important. So for 15 seconds, just quickly have a look of this dental council case of implants. Okay, and tell me what you can see. Okay, 15 minutes finished. People has been looking at the implants link that might cause nerve damage, right? Yeah, this is true. This is a case of a nerve damage. But when the dentists provide their dental records, the dental council is more interested than, to look at the patients have lots of dental problems. They have periodontal problems, have endodontic problems, have abscess, it's got untreated endo crown leakage, sinus infection, and things like that. If you have a patient with all these kind of trouble, please consider maybe shouldn't start your implants case yet, isn't it? All right. So the 4 things that you shouldn't do is that if your treatment planning is not prosthetic driven, all these things now is important. When there's a case that is coming up, we want to know whether your design of your crown, your superstructure is prosthetic driven or not. Helpfully, luckily, all the DIO treatment plan, they're started off with the prosthetic driven treatment plan. This is just to show one of my case that I did many years ago with the open flap, free-handed placing the implant. They're not prosthetically driven. All the crowns, they're all in like funny position. So, ooh, maybe I'm guilty already of something that I shouldn't do. That's another case that we place implant, and then we're looking at the implants. Oh, that's all good, very good. And then when I use the CD cone film to look at one of the previous implant crown that I've placed, perhaps I should aim the implants more towards the center of the bone so that the crown that I make can be more prosthetically driven. Well, that was more than 10 years ago that I placed that implant. So if I can have another chance, I prefer to place the implant more into the center. So that's why it's important that when you have your treatment planning, that you can assess and you can look at important things like the position of the implant and the records. And then you have to also remind yourself about the offset of each implant. Then it can then help you to, when you do the surgery, to use the appropriate drill, the drilling protocol of the surgical report. Infectious control is very important. When we do a full arch, there's a lot of implants that we need to place. Even though I have placed many implants, even though I can remember the drilling protocol of each size of the implant, I still put the drilling protocol in front of me. It is very good because when you get nervous, sometimes you don't, your brain got stuck. You don't want to think too much. And then you have a reference there. And then you also can confirm your next step with your staff, so we can work together. So the drilling protocol, it looks messy, but I always put in front of me when we do our surgery. Say for this full mouth case, and the latest surgical report is very good. I like it because it actually shows what kind of bone are we treating. It can, they give you all the direction when you place the implant, the hardness of the bone of each direction, so that you can determine how you do your osteotomy in order for you to be sure that every implant for the full arch case you place will have the enough amount of torque for you to immediate issue your breach. The five things that you need to be aware of is the difficulty levels. The difficulty levels is how difficult is the case. Is that too difficult for me or not? So the one thing that you can determine whether it is too difficult or not is you ask a question for yourself. Can you handle the truth? If something happened, can you treat it? If something happens, say, for example, have you got the experience if you perforate into the sinus? How do you handle it? Say, for example, when you place the implant and you found that's not enough bone, there's no torque. Can you handle things like that? A little bit of a complication. So if you think you can't handle those complications, maybe this case is too difficult for you, right? And the other things to determine whether this case is going to be more difficult for you or not is afterwards, if there's problems or complication, is the patient better off or worse off? So I always tell my patient what would be the worst outcome when you place this implant. My worst outcome was that maybe the implant won't work. It's not going to be integrating. And that's about the worst outcome. Not like I'm going to cause nerve damage or can't stop bleeding, or implant got into the sinus and I can't retrieve it and I have to send you to the hospital or things like that. Of course, those things happen, but we try our best to avoid it. And if you can't handle the truth, maybe that case, maybe it's a bit too difficult for you. So the sixth thing was that your surgical guide adjustment, and then you break the surgical guide. That's the things that you don't do DIOnavi system, when you have to intensively adjust your surgical guide. If you have to adjust so much, that's something wrong. Maybe your scan is not correct. Maybe the CT cone beam data is not correct. Maybe your treatment plan is too old, the teeth has moved. Maybe you're not aware of using a wrong surgical guide from other patients. You never know, they all look the same. If you have problems and you need to intensively adjust it, or causing breakage of the surgical guide, stop it. Start from the beginning. Go back to the first step, and maybe perhaps you have to scan the patients again, and don't continue. So the reason why you break the surgical guide during the surgery would be the angle or the insertion direction of your drill. It's wrong. Say, for example, if say this drill, without using your bone flattening drill, and you start with a 2 mm twist drill, because of the shape of the bone, it kind of push your drill to a wrong direction. And then if you keep pushing it, then the force can break the surgical guide. So the surgical guide help you to direct your osteotomy, the drill, into a perfect right direction. And if you have to force it down too much, there's something wrong. And then you can cause breakage of the surgical guide if the surgical guide is broken. Unless if you know how to do open flap and then finish off the surgery by opening the flap, then you can't continue. So the 7 things that I have made problems and mistake was the tissue punch and the abutment profile. Sometimes patients have loose gingiva. It's not enough attached gingiva there. When you place when you examine the patient, you ask the patient to swallow, to move the tongue. Sometimes part of the tongue soft tissue move into the area of your osteotomy. And then when you're using high speed, the tissue puncture might tear part of your tongue away, might tear the soft tissue away and cause big damage. And yes, your implant plays really well, no problems, but ending up you have to do a lot of stitches to close the wound. So when you use the tissue punch and the abutment profile, then especially when it is not flat, then make sure that you engage and examine. There's no tongue moving into the area, and there's no soft cheek moving into that area of your cutting. And then you turn the machine and do the tissue punch. Sometimes when you have a look of the situation like that, like area like this, this is soft and moving. And then while you're doing the tissue punch, patient might swallow, and this part of the tongue might move into the area and then cause some soft tissue damage. So it's maybe small things, but it's something that you should be aware of when you use your tissue punch, especially when you're using it with high speed. Be careful. And also your direction have to be careful. The 8th thing is, when we place implants, we want to place our implants with the right torque. The recommended torque for each implant when you finish would be about number 35 newtons per centimeter. That's a good torque. And you should be 35 or over, but nothing more than say 50, 55 or 60. That's when if you have to torque your implants too much, you kind of stop the blood supply to the bone, and then that might cause heating up and necrosis. So it will cause failure of your implant. If you under torque, then you can't load the implants. So your full arch cannot complete because you're placing 4 implants. If one of them is not enough torque, I recommend not to do your immediate loading. So if you can do this every time with the right torque, that is good. One more thing is I recommend you to use the ISQ. ISQ is it's a kind of becoming an international standard of how you assess your implant stability. So, and other thing also is you never assume things. And in this live surgery, we are going to show you to place 1 implant in the upper arch, 1 implant in the lower arch. So we always assume that the lower arch, the bone always very hard, and the upper arch, the bone is always very soft. But it's not always to be like that. So never assume. Every time when you do your osteotomy, you learn and you use your tactile sense, and you can modify your treatment plan according to the situation. So this is to show you, if you finish all your drilling from your protocol, then ending up, you have created an osteotomy of the shape of your implant's body, but there's still thread for you to engage. So if you finish the whole sequence of your protocol, that means you have created this shape that is the body of your implant, but you still have the thread for you to place your implant. So you can use this concept to modify. If you have a chance where you can't place your implants fully into the osteotomy with the right torque, then you can use your final tap drill to go down a little bit more to help you to sink your implants in. So this is a photo showing you that on the left side, you're not using your last profile drill into this hard bone. And then it's already up to 50 Newton centimeter, and you can't place your implants in. And then what do? Then you have to gently and carefully remove the implant and use your profile drill a bit more. And the right hand side, just to show you, after using the profile drill, you then can be able to place the same implants in the same position with the right torque. So the secrets of the DIO implant is that we are using a low speed drilling at a low RPM without irrigation. This allowed us to harvest the patient's own bone with the drill. And from that, we can observe the bone that we retrieve out. And then that can give you some kind of indication of how hard is the bone. Say if it is a D1 bone, the bone that you retrieve, that you harvest, would be like a white chalk color with not many, no blood in it. And that's a very hard bone. And then if it's got a little bit more red color, and then the bone is not as dense, and that's kind of like a D2 bone. So you can kind of use it to give you the indication of the type of bone that you're treating. And then the D3 bone would be very wet and loose, and then with more blood. And then the D4 bone is, you can't even see if there's any bone in there when you from your drill. There's not much bone there. And this surgical instrument that we use. And this is called a bone abutment profile drill. And this one also have to be careful because that also might drag this loose gingiva and cause some soft tissue damage. But it is important to use them because without using them, you might have problems placing your healing abutments or your customized abutments because there'll be some bones stopping you from sitting the abutments in. So this is an X-ray to show you that the healing abutment cannot be fully placed into that implant because of the adjacent bone that's stopping it. So you need to use that abutment profile drill to create this space so that you can place it. If you just let the patient go like this, then you're going to have problems because the micro gap there will cause infection. The ninth point that you really shouldn't do is about burning the bone. Burning the bone will cause failure to your implants. So we're talking about irrigation. So remember, every time when you change the drill, your drilling time should be less than 10 seconds for each drill. And every time when you change to your new drill, you have to do irrigation. And you'll get your assistant to irrigate all the way to the deepest part of the osteotomy to cool down the bone. Cool down the bone, irrigation, very important. Now, the last point that I want to mention is instrument disappearing. So every time when we do our surgery, afterwards, we count all the instruments. Make sure that all the instruments, how many gauges are there, it's all there. If there's missing instrument, it's a panic. And when do you get missing or disappearing instrument? Is a lot of time is when you're not very careful. So you dropped parts into the patient's mouth. So I suggest that if you have loose component, you should tie them with a dental floss before you sterile them. And then when you use it, then make sure that you can retrieve that small parts. And the other thing is the implant carrier. When you place the implant, when you place the implants in, sometimes the inside of the osteotomy, one side you have soft bone, the other side you have harder bone. And when you drive your implants in, then it shifts to one side. The hard bone is hard for the implants to stay, though the whole implant shift to the left side, to the area where there's softer bone. Because of that, you found that your instrument got stuck there. So you can't take it out because it's got locked in. So don't panic. Don't panic. For this situation, you can see the instrument have been shifted to one side and it's got stuck on the cortical bone. Then you need to get some kind of a crown removal to take it out. But the things about disappearing instrument is that when you use extra things like that, you have to be really careful when you get your things out from the surgical guide. It might drop into the patient's mouth, and then without noticing it, the patient swallows it. So you need to be extremely careful when you use when you take those components out. Make sure that you have all your fingers, many fingers to support your guide, your things. So to summarize what I've said, the DIOnavi system can actually help us to prevent a lot of problems. It can provide us with good dental records, good patient's consent, prosthetic-driven treatment planning, precise implants placement, a traumatic procedure, immediate temporalization, and a much better predictable result. So I have already spent some time talking about 10 things that you shouldn't do. Now, let's look at a quick video of just a simple implant procedure, and that when you observe it, see whether there's anything that can remind you of this surgery lecture. Let's move on to this quick video. Thank you. Now, this is the remind you about the prosthetic-driven procedure. This one reminds you about the infectious control record. Now, we try in the surgical guide. See how easy it is to place the surgical guide?
In case if you need to do any adjustment.
And if you need to do any adjustment,
on the
that you don't touch the occlusal stop.
But it's just like maybe here, this proximal area, the pointy bit, maybe sometimes it gets caught into the undercut, then you can trim a little bit, but make sure that the occlusal stop is not touched.
So this kind of reminds you about, like, you always have to support the surgical guide with your finger. And when we do our activation, we do that before the surgery. I've seen people doing the activation during the surgery when with your gloves with blood and all that. Then you're ending up contaminating your machine, your activator. It's very hard to sterile that activator. So activate it before the surgery. So look at how easy it is to fit in the surgical guide, and it's very sturdy and stable. And every time when we do our drilling, you stop supporting.
Okay.
And that is the tissue puncture. Okay. Remember the tissue puncture? Engage it first before. Make sure that there's nothing moving into the area of cutting, and then we press down so that we won't damage the soft tissue. And when we do the drilling, I never leave the surgical guide or any instrument in the mouth without any support. So that's a good the tissue puncture will clear that up. Good support, good stability, and then we go on to our next step. And when we're doing our drilling, even though we say we don't irrigate, but we do. So a gentle irrigation while we're doing the osteotomy, it's always good. And then we examine the bone that we harvest. So when we do our osteotomy, we don't want to heat up the bone. We talk to ourselves about the timing. Engage first, and 1, 2, 3, 4, 5, and examine the bone that we harvest. That gives us an idea, and also kind of remind us. One of the things is we never assume we are doing this upper arch. I thought upper arch the bone is soft, but not really. It's quite very dense bone. So observe the kind of bone that we harvest. Have to thank our cameraman. Our cameraman got such a steady hand, and he zoomed into this area, and I keep moving my hand, and then he's chasing the camera with the iPhone. It's really good. So the whole procedure shouldn't take more than 10 minutes. Good stability, engage, and then go to the white, to the first line.
How's the bone?
Look at the what we harvest, and then we kind of be able to give us an idea of how hard is the bone. So every drill, when we do it, we have to appreciate it, and we have to enjoy it, kind of. So I enjoy my work, and that is the abutment profile. All the way into the osteotomy and cool down, cool down. Very good. Now this step is very, very scary. So we need to carry the implant fixture, make sure that it's fully engaged into that. And then we place it in. Make sure the direction and the angle is right. And then we can observe the torque level, and when we nearly finish, we stop, and then we can then use our with our torque range to test. Wow, that's a hard bone.
Second line. With torque.
Very good bone. So kind of surprised me a bit, because it's the upper jaw. Wow, very hard bone.
Very good. We put the torque 35.
But we finish at 35. Now, when we take our instrument out, make sure one part at a time. One part at a time. We don't want to drop anything into the mouth. See, we can't, it's stuck in there. Use our periosteal elevator and help us to elevate it out gently with our finger support. Because this is the finishing of the, just to show you the 10 minutes that we finish.
It's finger tight.
And then we test the with the ISQ. That's good. That's very good. So mesial distal, it's nearly 80. So when we place the healing abutment, you can see my fingers supporting it. I don't want to drop anything into the mouth.
15. Good.
That's good. So I'm assuming that, wow, the top jaw is so hard, the bone. So the lower jaws must be very, very hard. But not really. When I do the drilling, and when I look at the osteotomy. Now, again, just to show you, it's actually quite quick. So you can see when we do the drilling, always support with your other fingers. So the surgical guide is stable and it's not lifted up. So sometimes when your insertion angles is wrong, the whole surgical guide may lift up without you noticing. Then you're ending up placing the implants into the wrong direction. So the cameraman is good. Technology is amazing. iPhone can take so good video that you never can think of. I'm not promoting iPhone, but they're good. They're good. So at the end, I found that I couldn't be able to achieve 35 newtons. I was assuming that the bone is good. So I finished off with the last profile drill all the way. So if you have one implant that you couldn't be able to achieve the right torque, you can't issue temporalization. So if you promise your patient that you can do implant in 1 day and then full arch, and then you can't give them the full arch, they're not very happy about it. So that's why every implant that we place, we learn and we train ourselves so that we can place implant correctly every time. So this is the front approach to the left side. So the other approach is you can use and train your left hand to do this. Irrigation, very important. That's the scary part. So I must admit, we finished drilling, but couldn't get the right torque. What do? I just test it again. This one is with the stopper. So I tested. No, not enough torque. I go a little bit more. Not enough torque. So I need to kind of place the implant a little bit deeper than it should be in order to get the right torque. So So at the end, I can achieve the 35 Newton, but my implant's position is slightly deeper than it should be. So let's see the ISQ.
Closer.
So it's not too bad. Anything more than 70, we are happy with. So we still place our healing abutment. Now you can see this is also finger support. I never leave the instrument in the mouth without any finger support. So always have fingers in there. It's very important. See, always have fingers holding it. Make sure that okay. So that's the X-ray, and because it's sink down, I need to remove this healing abutment and use my profile drill to create more space for the healing. So that actually completes the video. This video is simple, but actually, if you look at it, you still can learn a lot of things. So every implant I place, I try to learn from it. So if only we can do things better for our patient, we'll be happy. So thank you very much for your attention. I hope that this lecture can help everyone. Thank you.